And we will move on with our next item. And that is by our speaker, Dr. Sonali Nanda, and you have been hearing her throughout this symposium. She is one of our very own residents here at University of Oklahoma, a PGY2, and all the way from Charlottesville, Virginia. And so she is here at OU. She completed a Master of Science in Narrative Medicine at Columbia University. And prior to medical school, she was at the University of Virginia School that was at the University School of Medicine where she was. And then she also did a year-long research fellowship in dermatology at the Philip Frost Department of Dermatology and Cutaneous Surgery at the University of Miami. She is an author of multiple publications and interests and passions including hyperpigmentation, melasma in skin of color patients. And she aspires to specialize in Mohs surgery. She has been taking notes feverishly throughout this whole entire symposium. And so she is going to come now and give us our wrap up for the day. Dr. Nanda?
Thank you, Dr. Allen. That was very great of an introduction. Thank you. I've never been introduced before. But we just want to go ahead and wrap up the Skin of Color Symposium because we had such amazing talks today that I just want to hit some of the high points in the last 10 minutes. Let me see. So I have no disclosures. So thank you so much for our incredible speakers. We appreciate each and every one of you for coming during the day, providing your insightful information. We had a whole host of incredible speakers along with our panelists who I have not been able to include on this slide. So Dr. Woolery Lloyd talked to us about African-American hair and scalp disorders. First, she went through the unprocessed hairstyling methods such as afros, locks, twists, braiding with cornrows, and multi-tufted braids. These are somewhat natural hairstyles that the afros are the only kind of hairstyle that are not associated with hair loss. The rest of them can actually lead to traction alopecia depending on how heavy they are, how long they are, like she said. Some of the more processed hairstyling methods were extensions, where she discussed the ingredients in the glue that could actually cause anaphylaxis as well as scarring. Hot combing, chemical relaxers, and then keratin treatments such as Brazilian blowouts. So what was new in CCCA for her is she wanted to share hair grooming influences disease expression, but you do see this in men and women. Patients with more severe CCCA practiced frequent braiding or weaving compared to the less severe. And there has been a genetic link in mutations in PADI3 associated with CCCA. We all know that intralesional steroids can help, topical steroids can help, minoxidil, oral antibiotics, and PRP and hair transplant. I believe she mentioned topical metformin as well, which I hadn't heard of, and I was really interested to hear that it did so well on that patient on the Vertex scalp. So some really high risk hairstyles with traction alopecia were the tight buns or ponytails that are high up on the head compared to the low ponytails, weaves, braids, tight braids, cornrows, dreadlocks, and any hairstyle that causes pain and that you have to take pain reliever for afterwards. So FFA, it's actually in African-American women, the age of onset is earlier. 39 to 75% present with premenopause diagnosis of FFA. It has been linked to sunscreen use, but it hasn't been fully proven yet. And ILK and 5-alpha reductase inhibitors have the best responses. Dr. Woolery Lloyd really impressed upon us that avoiding hairstyles that cause pain could be one of the best ways to assess whether a hairstyle can cause scarring hair loss in the future. So thank you to Dr. Woolery Lloyd. Next up was Diane Davis. She was coming from Dallas, and she talked to us about her lasers in ethnic skin. A little epidemiology and pathophysiology. By 2050, 50% of the US population will be comprised of skin of color patients. And it's important to know that ethnic skin has increased epidermal melanin, labile melanocytes, and reactive fibroblasts. She emphasized the importance of doing test spots on certain skin just to make sure that there isn't post-inflammatory erythema, and you don't want to do the whole face if you know the test spot is reacting. So Dr. Davis usually uses 1064 ND-YAG for her laser hair removal most of the time. It's the #1 laser procedure across the board. There are longer fluences, longer pulse durations. She uses epidermal cooling, which is a very important characteristic of her practice because it decreases melanocyte disruption, and topical steroids afterwards as well as sunscreen. For benign epidermal lesions, she showed some really great examples of targeting like SKs with YAG laser therapy, complete resolution of 85% of lesions and near complete resolution of 15%, with no evidence of scarring, discoloration, atrophic or pigmentary changes, and very minimal post-inflammatory hyperpigmentation in these patients. There was also a really amazing example of using milia. Or using the YAG laser for the therapy of milia as well. This patient was very compliant with the post-procedure processes of sunscreen and steroids, but you can see that this kind of therapy was targeted to a 0.2 millimeter spot size that really helped her get each of the milia on the side of this Asian lady's face. The coolest thing that I thought about Diane Davis's PowerPoint was her acne scars and how she treats them. She went over how she treats mixed acne scars. So they can come in many different varieties, the ice pick form, boxcar, or rolling. Sometimes it's hard to tell what kind is more prevalent because they're all kind of mixed together. That's what I have trouble with, but it's important to evaluate the type of scar and then assess the risks of pigmentary alterations or scar formation based on how their previous trauma has healed. So you can ask a little history there. But her acne surgery protocol was fascinating. She starts them on oral tretinoin 2 weeks pre and 2 weeks post treatment. They do tumescent anesthesia and then use a subcision method called the Taylor Liberator, where they have this specific device that goes under the skin and breaks up the scar tissue. And then after that, 20% TCA chemical peel, 6 passes of 2 or 3 different kinds of laser. I know it was SP Dynamis, and then there was also one called Sono something. I think I'm going to have to ask her about that, but and then she does PRP, and then 100% sun protection after that is super important because this is very invasive. It is ablative, and we want to make sure that they don't hyperpigment. So these are some incredible pictures of hers. I think that they're both really striking and just so well done. So next up was cutaneous lupus across skin tones with Joe Monroe and Dr. Zicker, who's a rheumatologist. It was very interesting to hear their perspective of a very common dermatologic disease, often goes misdiagnosed or unrecognized in skin of color patients. So the early diagnosis and treatment of lupus in skin of color patients is essential. However, it's difficult because patients with skin of color are underrepresented in medical education. Rheumatology and dermatology are about 5.3 times less likely to publish an image of a patient with lupus and skin of color compared to equal representation. They went over discoid lupus first. It's the most common form of cutaneous lupus, and it occurs in about 40% of skin of color patients. Some of the risk factors are Black female patients, smoking is a big one, and UV light exposure, as well as proven genetics. For example, if a Native American patient is seronegative, but someone in the family, mother, has lupus, it is definitely something to look out for. Tips to visual cues. I really liked this one of having enlarged follicular ostia and tacts, the hyperkeratotic spikes. So the time course of DLE to SLE depends, but usually it's within the 5 years of diagnosis, and about 20% of patients progress to SLE. So we are pretty familiar with the serologic testing for lupus diagnosis, and they wanted to go over the fact that ANA is a non-specific antibody. It is a naturally occurring antibody that is used to clear cellular debris. You should interpret ANA titer within the specific patient population, and you can order an ENA for supplementary information. Next up was Dr. Bowers, who gave a really compelling talk about decoding unconscious bias in medicine. It was really lovely to hear her talk about how important someone's name is, and I felt seen during this talk because I know that my grandparents had to change their names when they came from India here. My grandfather's middle name was Pal, it's P-A-L, and he just changed it to Paul so that everyone would have no problem understanding where he's from, and his name's Paul, he's American. So it was interesting to hear her take on that. So first, she went over equity versus equality, and unconscious bias comes down to our central purpose. What is just, what is equitable? And I love this cartoon that she showed to represent that. So disparities have continue or have worsened since 2002, since we started to study this more closely. It's been shocking what we have found. Unconscious or implicit bias is an evolutionary tool to recognize threat or the unfamiliar and compare them to our familiar. And we do have unconscious biases as healthcare professionals. We tend to, these are some of the very general ones, but tend to associate Black men with violence, obesity with laziness, height with competency, and male gender with a stronger leadership. Unfortunately, physicians and nurses do exhibit bias to a similar degree as the general population, as much as we would wish that we did not do that. For example, dermatologists are more likely to order HIV RPR in Black and brown patients, and we lack training on images of color. So certain things that we can do to limit our unconscious bias. One of the biggest things is that you're here today. This will increase our awareness, increase the conversation we have, and continue this process of learning and being more open to hearing others' perspectives. Next up was the amazing Angelica Das. She was talking to us from Spain, and she talked to us about her artwork and her life's work in the beauty of human skin in every color. She has had workshops all around the world. And one of my favorite things that she said is, we come from the same material and yet we are uniquely different. And we had an extensive talk with Angelica Das. We can all reach out to her if we need to. Dr. Susan Taylor was up from UPenn, and she gave an incredible talk on the Fitzpatrick skin types. And she also featured Angelica Das in her PowerPoint. So Dr. Fitzpatrick created this assessment to assess skin burn. It was not supposed to be an evaluation of skin pigmentation, but it has kind of turned that way. It has been expanded from 1 to 4 to 1 to 6 over time. It is not constituted, or Fitzpatrick skin type is not a direct correlation to skin color or ethnicity. However, many board certified dermatologists and dermatology trainees do use it as such. So it was really interesting to see that in the graph she showed us, the predominant Fitzpatrick for each racial type was all across the board. 11% of Blacks reported burning moderately or very easily, so that would put them in 1 through 3. And 39% of Caucasians reported tanning moderately or profusely, so that would put them in 4, 5, 6. We went over Wendy Roberts' skin classification system, and hers was a little bit more involved. It had 4 different elements in it, and it helped identify the skin's likely response to insult, injury, and inflammation. And then Dr. Taylor's hyperpigmentation scale was also really interesting. It was just purely visual, and where she had 15 colored plastic cards that span the full range of skin hues, and that could be definitely used to describe the skin pigmentation of the patients that we're seeing as well. Next up was Anisha, one of our own medical students, who talked about a huge study that they've done the last few years on Fitzpatrick skin type self-reporting, accuracy versus provider reporting. We went over the objectives with her, and these wonderful graphs show us how the breakdown was of the 500 surveys they collected over 18 months. Results showed that the provider assigned Fitzpatrick was more accurate than the patient's own estimation of their ability to tan versus burn, which was pretty encouraging for me to hear. And then the patient underestimated redness, irritation, tenderness, itching, but not skin color change. So the implications are that patients do not accurately identify their Fitzpatrick skin type. It's very important for us to educate patients and provide expert advice on how their skin's going to react to laser procedures or cosmetic procedures, sun protection counseling for them, and what is the appropriate use of Fitzpatrick in a dermatology clinical practice. Next up was the amazing Dr. Cannon, who gave us an amazing talk about her own journey through medicine. She talked about her personal challenges of being an underrepresented minority as she navigated a career in medicine, the difficulty she had overcoming teen pregnancy and coming back on her cheerleading team, and then deciding, you know what, this doesn't feel right, and leaving it. And then everything she had to go through along the way. It was just the most inspiring thing. And we talked about the synergy or dyssynergy, I guess, of the dual identity of race and gender. For example, the difficulty Black women have in academia, and how important it is to have diversity in medicine. It helps us meet unmet needs of growing diversity in our society. The minority physicians are more likely to practice in underserved communities. As family medicine or primary care practitioners, they're more likely to care for patients on Medicaid, and they improve racial understanding. So I want to thank everyone who talked today and all of our wonderful panelists. We appreciate you so much. We've learned so much throughout the day. Key points from the panel discussion are that as physicians, we would never want our patients to not receive the highest quality of care. We want everyone to have the benefit of access to high quality care, regardless of their skin color. We have to go out and talk to people to understand where they're coming from. They're not necessarily going to come to us. And this is a huge paradigm shift that needs to occur across institutions. Institutional memory can be very short, so we have to continually remind and increase awareness. We want to thank you from our, it's a little blurry, but this is our residency class. We're a whole mixture, and we have a great time together, and we hope that all of you all enjoyed today. So thank you so much.
Thank you, Dr. Nanda. That was a wonderful recap. And I think that's going to help us really impress that within our minds and remember it for time to come. And so we are at the very end, and I want to say thank you. I'm going to just share my screen very quickly. Let's see if I can get it to the right one. And say thank you. First of all, let me see if I can get it There we go. I want to say thank you, first of all, to all of our wonderful speakers. They're coming from all over the nation. And I'm just so happy that they took time out of their busy schedules, even virtually, to be able to be with us and to continue our vision and mission when it comes to education within skin of color and some of the societal issues and diversity issues within academic healthcare systems that we face. And it's programs like these that give us an opportunity to have a forum to be open. It's a safe place to talk about issues that may not always feel comfortable in other arenas, but it allows us to, each of us, to be empowered to not only be allies, but to be active participants in equality for all. We want to also thank our moderator, Dr. Natasha Michael, and all of our panelists for their insight and input into DEI within academic healthcare systems. We want to thank the CME office, that's Myrna Page, Jim Albertson, Susie Deely. They have been working ever so hard to help put this together. They are working behind the scenes even now, and I want to thank them for making this a successful program as well. I want to thank our OU dermatology residents and their participation in this program. Couldn't do it without you, and I must mention my administrative assistant, Renee Wall. And she is the one that's kept me on track from day to day. And it has been amazing to work with her on this project from each year. And so thank you, Renee. And I want to thank also our sponsors. Again, the Mark Allen Everett Foundation, the Everett Family Affiliated Fund, which is housed at the Oklahoma City Community Foundation. If it wasn't for them, and their financial support, this program in the most part would not be possible. So thank you to the Everett Foundation. And we also want to mention Doctors Betty Pfefferbaum and Dr. Richard Van Horn and Dr. Rose Pfefferbaum, all of them who have supported this program financially. We thank you so much. And I want to leave you with this. Save the date now. Next year's Skin of Color program will be Friday, May 5th of 2023. And we are using it on the Friday before Mother's Day. And so just mark your calendars and you'll be receiving more information about that down the road. So we want you now to be able to fill out the evaluation forms and let us know what you think about our program. And anything that you feel that maybe we should include for next year, or maybe speakers that may be wonderful for our symposium that you'd like to see included, please let us know what we can do better. This is a work in progress, but this is something that here at University of Oklahoma, we're proud of, and hopefully that it will be an enriching educational program for everyone around the nation. So thank you so much. We wish you well this weekend and have a good evening. Thank you.